Second case is a 71-year-old female who had ESBL UTI that developed into urosepsis. She was in the hospital for a very long time, and on day 154, she was being treated for this ESBL E. coli sepsis with meropenem and linezolid, so pretty big antibiotic guns. Her respiratory culture on that day grew E. coli 100,000 CFU and then Acinetobacter 100,000 CFU. We have a sample from that day that we analyzed with our T2 test, and that was positive for Acinetobacter. Blood culture on that day was negative. 2 days later, the team added tobramycin to cover Acinetobacter based on sensitivities. And a few days later, her respiratory culture grew a much better looking culture, so 2,000 E. coli, 900 Acinetobacter. She was discharged several days later on dialysis, but she did survive her hospital stay. So what was the role of T2 in this case, or what could have the potential role been? T2 identifying Acinetobacter, but not identifying E. coli, could have been a signal that Acinetobacter was not being effectively treated. E. coli was susceptible to carbapenem, and the patient was on meropenem, so she was being appropriately treated. But Acinetobacter was resistant to carbapenems, so the team adding tobramycin was effective, was the appropriate step, and we see a much better culture a few days later. So this highlights the role of T2 in identifying potentially resistant pathogens in a patient.